Once again, good afternoon, everyone. My name is Franklin Alaya. I'm a co-founder of the Northern California Spinal Cord Injury Foundation. Welcome to tonight's presentation along with my fellow co-founder, Nick Struthers. We're thrilled to be able to make this event happen and have someone of some incredible talent and knowledge and experience in the spinal cord injury field talk about these really breakthrough clinical trials that are going to be held involving nerve transfers. So I'm pleased to introduce Dr. Ray, Wilson Ray. He's a professor of neurosurgery and the chief of spine surgery at Washington University in St. Louis. He is the vice chair of clinical operations and director of the joint neurosurgery, plastic surgery, and orthopedic peripheral nerve fellowship. Dr. Ray completed his neurosurgery residency and a peripheral nerve fellowship at Washington University. He then completed a fellowship in complex spinal surgery at the University of Utah. He has extensive National Institute of Health and Department of Defense funding for his work in cervical myelopathy and nerve transfers for tetraplegia. And I'm pleased to introduce you all to Dr. Ray. Just keep in mind that we are taking questions by using your chat feature. That's towards the bottom of your screen, and we will answer all your questions upon the conclusion of the presentation, which should be in about 45 minutes. So there should be plenty of time for all of your questions. So without further ado, Dr. Ray, thank you.
Great. Well, thanks, Franklin. Thanks for hosting this tonight. This is nice that I had the opportunity to present this work to you. I thought what I would do is go through the trial itself, of course, but then also just give a real nice overview of peripheral nerve surgery and how this might be applicable to the setting of spinal cord injury. So I'll go ahead and jump right in. And I think where we're at now is, where we were 5 years ago and 5 years ago before that, so to say, is we're making progress, but we really had not identified a sort of intervention or therapy that provides a robust and sustainable improvement for spinal cord injury, and in particular, tetraplegia or spinal cord injury at the level of the cervical spine. And so the question is, why are we talking about peripheral nerve transfers, and why would we be interested in this in the context of spinal cord injury? And this is a diagram that most medical students become nauseous by when they first see this in medical school. And it represents the area where the nerves come out of the spine. And then these eventually divide and join together to form the distal nerves that provide motor and sensory function to the upper extremity. Now, peripheral nerve transfers, this is not new. It's been used in the context, if you imagine, again, injury here to the upper nerves as they exit out of the spine is a very common thing that we encounter after a motor vehicle accident, motorcycle accidents, ATVs, and people are left with loss of function in that very specific distribution, either shoulder or bicep, and in some cases involving the entire arm. But it's injury not to the spinal cord, but to the nerves as they exit out. And traditionally, or the way that I trained to manage these, is we would take nerve, oftentimes from the lower extremity or the leg, and we would take that nerve graft and cut out the area of injury and sew this nerve in. And the results of that were not great. As you can see, this gentleman here, this was actually a good result. After a very large, extensive surgery and grafting, this was a good result because he had return of function for elbow flexion. And so there really was a desire, but also a significant need to identify an alternative therapy or intervention. Now, I was fortunate, the plastic surgeon that I trained with in plastic surgery when I was doing my training had expertise, but was also one of the real innovators in developing nerve transfers over 20 years ago now. And the idea behind a nerve transfer is using redundant motor function or sensory function to reinnervate a more critical area of nerve function. Ideally, this would be pure motor fibers if you're trying to reinnervate or reanimate the hand per se, or elbow flexion or elbow extension, and also has a large number of donor motor axons. We're not downgrading or taking away function. We're taking redundant function. So in contrast to what I showed, where perhaps you would cut out that area of injury, in the case of a nerve transfer for a brachial plexus or a nerve injury, we would effectively bypass that injury. We would take redundant function from preserved or normal nerve and reroute that to reanimate the area of interest. And so again, keeping in mind, this is what we would typically see as a good outcome. This is the type of results we were seeing with nerve transfers. So very, very different and much better return of function with nerve transfers by bypassing that area of injury. Now, nerve transfers being around for decades now, there's a nerve transfer for effectively any distal distribution or any nerve distribution for function. And we've gotten very savvy at these in regards to reanimating predictably in a reliable fashion areas where that nerve is no longer functional. So this is an intraoperative picture. You can see the lower tricep or the back of the arm there, where we've taken, in this case, part of the tricep nerve to reanimate or reactivate that shoulder function. So providing return of shoulder abduction, which is a common deficit for brachial plexus injuries. Similarly, the other injury that or muscle loss is oftentimes elbow flexion. And so we would take some of the ulnar nerve or some of that redundant function for hand flexion to reanimate elbow flexion. Now, these are common transfers that I do on a regular basis in my practice. And these are ones that are well established with reliable return of function. And this has gotten to the point where we can do complicated reconstructions for even entire avulsion or loss of entire arm function. So I'll pivot and now provide some relevance. Again, why are we talking about nerve transfers? And just by the nature of my practice, this is a common scenario that I would encounter. In fact, this was a patient that I took care of. He was a young, healthy gentleman, no other medical problems, and he suffered a complete spinal cord injury while at football practice. We urgently took him to the operating room and reduced the subluxation, took the pressure off the spinal cord, but unfortunately he didn't have any meaningful return of motor or sensory function below that level of injury. And as you might expect with his level, he had good proximal function, so he had good shoulder function, he had good elbow flexion, and he had some wrist extension. So he did have some preserved tenodesis effect, but really no distal motor function for hand or elbow extension. And so typically at 2 years, when these patients saw me prior, if their x-rays looked like they had healed, they had fused, as is the case here, there's not any additional therapy that we could provide. And that was really the crux of it for me, is providing some sort of intervention or some sort of additional opportunity for return of function, particularly in patients with a chronic spinal cord injury. Now, everyone on this call or on this webinar can appreciate that this is a devastating and significant public health problem. And there's about 260,000 Americans currently living with a spinal cord injury, and the majority of patients or individuals are young and they're in their most productive years of their life. There's 250,000 new spinal cord injuries worldwide on an annual basis. About half of these occur at the level of the cervical spine, resulting in some degree of tetraplegia. And hand function consistently is rated as that most desired function. If you could just get some distal return of function below the level of the injury, that would significantly improve independence and quality of life. So again, how, why are we talking about nerve transfers? In the context of what we can achieve with nerve transfers for peripheral nerve injuries, I asked the question, why can't we do this for spinal cord injuries? Now, unlike peripheral nerve injuries, where we have a very finite amount of time, 6 to 12 months to reinnervate that denervated distal motor end plate or the muscle that was supplied by that nerve. With spinal cord injury, there's no disconnect. Spinal cord injuries result in upper motor neuron dysfunction. And so effectively using those same principles that we used for a brachial plexus or a peripheral nerve injury, we can bypass that same zone of injury. So in this case, someone with a C7 spinal cord injury still has good elbow flexion, good shoulder function, and we can take that less critical elbow flexor, the brachialis, to reanimate finger flexors. Now, there's three categories that we might think about, or when I think about treatment for reanimation, we have that area above the zone of injury and that normal volitional control. You have the zone of injury, or the area where the spinal cord has been damaged or injured. But it's this area here, that area below, where there's upper motor neuron dysfunction, where I mentioned those nerves are still in continuity. They're still connected to the muscle. And the question is, are we up against that same time frame? And I can tell you the answer is no. The answer is we have a longer period of time than what we would have for a peripheral nerve injury. And so a common patient that I might see, just to give this, I guess, some relative, if you can conjure this up, this is a C6 patient. Now you have that area above the area of injury. That's where our donors are going to come from. In the case I showed you, the brachialis, and we would reanimate that target or that territory below the zone of injury. Now, the reality, and what's become more and more comparative, is that zone of injury can be quite variable. And that gets into the next question is, well, who's a candidate? How do you go about patient selection? Who's a good candidate for reanimation or nerve transfer? And effectively, it's 5 things that I look at: the history, the physical exam, electrodiagnostic studies, and functional electrical stimulation. I'll talk about all of these, but most importantly, and number 5 is we have to differentiate that upper motor neuron dysfunction versus lower motor to ensure that that territory is going to be responsive to reanimation. Now, history, neurologic stability, that's probably the most important. We don't want to intervene on anyone that's still making functional gains or having ongoing functional return. So they've plateaued in regard to their functional gains and improvement. Appropriate expectations, we're not going to return normal function. We are going to have some return of function, but it's not going to be pre-injury. Appropriate social support and motivation, and then just good general health to tolerate surgery. On exam, that territory that we might take as a donor needs to have near normal function. The joint or the area that we're planning to reinnervate needs to have good preserved range of motion. And then I'm also, again, looking for this upper motor neuron versus lower motor neuron picture. Nerve conduction studies, these are always done now. And when I first started doing these, did not appreciate the importance. But if we look at a nerve conduction study in a spinal cord injury patient that has preserved connectivity, we'll see an intact activation of the nerve. And these numbers are less important, but what is important is these numbers are near normal. And that nerve is functioning just like a normal nerve. It's just not carrying the signal because of the functional block at the level of the spinal cord injury. Now, who's not a good candidate? What would that look like? Well, it looks like a lower motor neuron phenomena that doesn't respond. There's not any activation in that nerve because it's not connected to the muscles any longer. Functional electrical stimulation. This is used both intraoperatively and preoperatively. It gives me reassurance that it is, in fact, an upper motor neuron distribution, or that it's going to be viable for reinnervation. And then intraoperatively, I can very precisely identify my recipient target nerves, and allows for precise vesicular selection for reanimation. Now, with brachial plexus injuries, the goals of reanimation are different. As I mentioned, again, those tend to be we're working to reanimate proximal to distal, whereas with a spinal cord injury, we have preserved proximal function, and we're trying to reanimate distal function. So elbow extension for transfer, palmar grasp or wrist extension for tenodesis, fine or key pinch, and then release, finger extension and wrist flexion. So the nerve transfer that I showed at the very beginning, the same picture you see with the incision on the back of the tricep, only it's the opposite. Instead of taking that tricep and transferring it to the axillary, we're going to take a component of the axillary nerve to reanimate the tricep to restore the ability to transfer or elbow extension.
Here's the tricep branch. You were spinning.
Intraoperatively, as I mentioned, I can stimulate that nerve to have reassurance that that is going to be a viable territory for reanimation. Nerves are generated at 1 millimeter a day. There's no way to speed that up. And so these transfers start to show signs of reanimation depending on the distance of the transfer. This one is a relatively short distance. So at 6 to 9 months, we might expect to start seeing some evidence of reanimation in that territory. But by 18 to 24 months, patients have usually recovered to the point of where they're going to be at that 24 or even 36-month time point. And here you can see this patient has not normal function, but pretty darn close to near normal function to where now he's able to self-transfer. So preoperatively, this is the C6 spinal cord injury patient. I've taken away his tenodesis, or his ability to finger flex there, and without that wrist extension, there's no median or ulnar hand function, so no finger flexion and no wrist extension. The common transfer we might do, or a strategy for reinnervation, as I showed in the diagram earlier, is taking this redundant or less critical elbow flexor, the brachialis. We're leaving the bicep intact, and we're rerouting that nerve for elbow flexion from the brachialis into the median nerve. I can very precisely identify the distribution for finger flexion, and I'll just show this here. You can see intraoperatively, I'm activating that median nerve, or the territory for finger flexion. And this gives me reassurance that, one, the nerve is viable, but two, I can very precisely target where I want the reanimation or the regenerating nerve to be targeted to. So finger flexion, that is nice, and at times we don't have options to provide release as well, but if I can give grip and release, that's a significant improvement and a significant advantage in terms of the functionality. The bicep is the strong supinator, or the muscle that allows you to turn your palm up. The posterior interosseous nerve is the nerve that drives finger and thumb extension. Because the supinator is redundant in its function, we can take this distal nerve that arises from C6 to reanimate the finger extensors. And here's the exposure for that. Labeled as that posterior interosseous nerve. And we get a nice, strong activation, giving us reassurance that's going to be viable for reanimation. Here's our donor, the supinator.
That was a little pretty weak, but there we go. There's some PIN.
So the question is, well, what are the outcomes? What are we achieving? Are these outcomes as good as what we had with peripheral nerve injuries? Are they as reliable? And I can tell you that this is a newer phenomenon. There are a few groups doing this around the world, a couple in Brazil, one in Australia, and then increasingly some in the States. And I can tell you that it's promising. It is promising in regards to what type of functional reanimation we can achieve. So these are C6 spinal cord injury patients, had preserved wrist extension, and so we're able to use the tenodesis. But even if we eliminate that tenodesis, you can see a nice finger flexion and release. Another example, again, the common transfer, the brachialis to the median finger flexors and supinator to the finger extensors.
Okay, now squeeze. Go ahead and open the hand. That's great. Okay, now relax.
Okay.
Open. Now open your ear. All right, relax.
So not normal and not close to normal, but dramatically improved. And this was a significant and life-changing improvement for all of these patients. So is it ready for prime time? Should we be doing this on a regular basis? When is this going to become available? And the question is, I don't know that we know if it's ready for prime time. We looked back at our own results, and although I just showed you pictures that demonstrated very good outcomes, some of these outcomes were not so great. Patients that on paper, on exam, look like they should be good candidates for re-innervation. And you can see this is not anything meaningful in regards to useful function. So this work, or the trial I'm going to introduce at the end of the talk, is based on a phase 1 clinical trial. This was sponsored by the Department of Defense, where we enrolled 20 patients to evaluate whether this was a viable option. This initial trial was a prospective. It was non-randomized. There was a single arm, and it was done just at Washington University. We enrolled only adult patients that had viable distal muscles that appeared to be viable for reanimation, as well as good proximal donors that had a stable exam with no evidence of functional improvement for at least 6 months. The intervention, and I'll go through each one, was tailored to the individual's functional deficits, and this was broad in regards to patient enrollment. We treated some patients with C3 and then all the way down to C8. And our primary outcome, or what we were most interested in, was what type of functional strength return that we could get in that reanimated area, but then also what was the patient perception, or what were their patient reported outcomes regarding the return of function. This just depicts the various transfers that we did. Some of these I talked about, some of them I didn't. As we get higher, with a higher area of injury, we have less donors, and so we have to be more creative in regards to the transfer options, but we're also more limited in the type of reinnervation or reanimation strategy we have. So there were 17 patients at the time this was written up, with at least 12 months of follow-up, so fairly variable range in regards to time since injury, but the median time since injury was 18 months for the patients that were included in this study. There were 42 nerve transfers and 26 upper limbs, and about half the patients had combined double nerve transfers performed, meaning they had both the extensor and the flexor function. And if we look at the results for extensor strength, the wrist extensor was very promising, on the order of 70% having greater than 3 out of 5 return of function. So not full strength, but very good and strong finger extensors, wrist extensors, and thumb extension, upwards of 70%. Our tricep was less reliable, and this was skewed a bit because we included some with grafts as well as some very high injuries, but still upwards of about 50–55% having good and functional return of tricep or elbow extension. Now, the finger flexors were much more variable in terms of viable and meaningful return of function, and you'd say it's much lower than what we might expect for the finger extensors, about 25%. And I would say my interpretation of this data is I wasn't happy with it. I was not happy with the finger flexor strength, and it was different than what my appreciation was in clinic. And that's because to someone that does not have function, that was a lot. Everybody universally came back and was happy with their function, even when I looked at these numbers and said, well, boy, I wish we would have given you some more power, because that 3 out of 5 or that 2 out of 5 function was very significant in terms of meaningful use, but also contributing to ADLs. And so although, again, this was less reliable for finger flexion, reliably and to significant levels, everybody was very happy with that return of function. Now, I'll give one final case for thought before I go into the trial itself. And this was a 30-year-old gentleman that was referred to me 10 years after a C3, or after sustaining a ASIA A C3 spinal cord injury. And he had, as you can imagine with the level, no movement aside, shoulder shrug through the trapezius. And the question was, is there anything that we can offer? And what we had thought was perhaps we could provide some return of elbow flexion. Well, as it turned out, everything below, all the distal nerves were functional, but unfortunately, the bicep was not functional. So we were not able to reanimate the bicep. But by taking that preserved shoulder shrug or spinal accessory nerve, we gave him a very nice return of function in someone that had not had anything but shoulder shrug for 10 years. So this is a year and a half, and he is probably one of my happiest patients with this elbow extension, which he still has some spasticity, but again, could not be happier with his outcome. So what did we learn during the first clinical trial, and how are we using that moving forward? Well, I think, again, what is not new and what we all still know is that cervical spinal cord injury is still a challenging clinical problem with limited surgical options for meaningful return of function in upper extremities. Nerve transfers may be an adjunct or a promising alternative. At least in my experience, this early experience, it seems that the nerve transfers for finger extension, for thumb extension, for wrist extension show a more consistent and meaningful return of strength and function, whereas the finger flexors are much more variable. When we did a post hoc analysis, what is also clear is patients that had earlier intervention or time since injury had a greater return of function. Now, the phase 2 clinical trial, and I'll just go through this and then open things up to questions. This is a broader trial, and I've included the 7 sites that will be participating. Again, the aim is the same as the first study, to evaluate whether nerve transfer surgery provides a meaningful improvement in both activities of daily living, but also return of strength in the reinnervated territory. We had 20 patients in the first trial. This will be 70 patients across 7 investigational sites. As you'll notice, these sites are spread out across North America to give patients better access to this sort of treatment. Thus far, the trial has been slowed by COVID, but there was a lot of pinned up patients ready and wanting to have surgery done. So we have, at this point, 5 total consented, 1 surgery has been completed, 2 have been scheduled, and 13 patients that are waiting for their appointment for evaluation. Again, these are the 7 sites. WashU, of course, will remain the main site, but again, as I mentioned, the idea was placing these across North America to give patients better access to this sort of treatment. Inclusion, we're still treating just adult patients with an ASIA A or ASIA B spinal cord injury that have had stable functional exams for at least 6 months, that have had at least 3 months of non-operative rehabilitation therapy. We're trying to treat patients earlier now, less than 36 months since the time of injury, but this is variable. We've certainly made exceptions for that, even in the first trial. Exclusion criteria, somebody that has ongoing or evidence of clinical recovery, is immunosuppressed, active malignancy, pregnant, significant joint contractures or limited passive range of motion, or some sort of active infection that would prohibit surgery. I just acknowledge I have a big team here that has grown over the years to provide support for much of this work, and my physiatry and rehab colleagues are a big part of that, as well as the hand therapists and the study coordinators. And then, of course, the institutional support from WashU. At this point, I tried to get through this a little bit quicker so I could give everybody a chance to ask questions. Thank Thanks for your attention.
Great. Thanks, Dr. Ray. If you can go ahead and unshare your screen. Okay, so we have some questions. First question, the person is basically considered an incomplete, but she has no function in her arm. So seems like one of the criteria of the study was that you have to be a complete injury. How do you sort of evaluate someone like that for this trial?
Yeah, and I think for the sake of, again, I think what we want to avoid is any sort of downgrade of function. And, the concern with somebody that's incomplete is taking away function. Certainly, if there's no motor function in that distribution and the muscle is still viable based on nerve conduction studies, they may still be a candidate for surgery.
Okay, fair enough. How is this different from previous approaches involving nerve transfers?
Yeah, I don't know that it is different. And I'll tell you, we've learned a lot along the way. We treated the first patient over 10 years ago now with nerve transfers for spinal cord injury. And at that time, we didn't know who was a good candidate. We didn't know what we were looking for on the EMG nerve conduction study. And I think that's changed because we're now better at patient selection, identifying people that are going to fall into that 70%, or identifying patients that are going to have good functional outcomes. Now, what that's done is it's limited this surgery, and not as many people are probably good candidates, but patients that are good candidates have a more reliable return of function.
Okay. And is there a similar approach for bowel function, or maybe has that been thought through in terms of what would be the next area that this would apply to?
Yeah, I think there is certainly a growing interest in bowel bladder function. And some of this work you may already be familiar with. Intercostals tend to be the prominent one looked at in regards to cervical spinal cord injuries and return of bowel function. I'm less familiar with the work, or if there's been significant progress in that area.
Okay. The question is, a C6 or a C7, C8, they should theoretically, for the most part, have good arm function, and certainly with some lower level C8, maybe some hand function. Yeah. Is that typically not the case? And so what would a C8 or a C7 be able to gain from a nerve transfer?
Yeah, I think the C7 is probably going to be a better candidate. That slide that I went through quickly, we had one C8 patient that we treated as almost a distal or peripheral nerve injury, because that pattern of injury did look like it was in the zone of injury. And so treating her before that 12-month mark, and that's why there tends to be far fewer C7 and C8. And the majority of videos I'm sure you appreciated were that C5, C6 patient population.
Okay, very good. Is it possible to do more than one nerve transfer, maybe one on the right arm for wrist and hand and another on the left arm for some other function?
Yes.
And that would be part of this trial? I mean, you folks would entertain those types of candidates?
Yeah, and I think, a lot of people, certainly in the first trial, if they were in the region, they wanted to do one arm and see what happened. And invariably, if they started to have return of function, they were very anxious to get in and get the other arm done. If people traveled in from a ways away, we might treat one arm and treat the other arm 2 days later. So of course they could get everything done while they were in St. Louis.
Okay. Talk to us in terms of the therapy, the follow-up therapy, the hand therapy that would be required. What does that look like? How long, how often, where, and all that stuff?
Right. So again, as I mentioned, I have a great team, and I have a hand therapist that has been working with us for many years now that does all the nerve transfer re-education. So we're teaching we're teaching the brain really, or the brain is undergoing re-education to have finger flexion be controlled by elbow flexion. And so that physical therapy, there's a lot of co-activation sorts of exercises to retrain till you have autonomous control. And so the physical therapy really involves a lot of cortical re-education. The nice thing with the Department of Defense clinical trials, it pays for all of the therapy afterwards to ensure that you're getting objective, consistent, but also similar physical therapy or physical therapy protocol that we're using here. And if somebody is away, oftentimes it's our therapist, Anna, that connects. And if the therapist doesn't have familiarity with nerve transfers, goes through the postoperative therapy.
Okay. And the therapies, do they need to be at selected therapists or locations, or they could be any?
As long as they're a hand therapist.
Excellent. So they can get the procedure done at any of the 7 sites, go back to their home town, wherever that might be, and find a hand therapist and continue on.
And I would tell you that is more than half of the patients that were enrolled in the first trial.
Okay. Right. How firm are you on the sort of 3 to 36 month time frame?
Well, as I showed you, I'm not, I obviously, the 10 years out, I was very pessimistic that we were going to have a good return. And we had a couple C3 patients that were a ways out from injury. And one of the 3 did not have that same nice outcome. But I don't think we know. I don't know that we have a window. We saw that trend that I mentioned, that patients that had intervention earlier had a better outcome. But there's clearly patients that come in that are 5, and the patient that was 10 years out, that his EMG nerve conduction study looks normal. It looked normal, which gave me some reassurance that reinnervation was going to be a good option for him.
Okay. This next question may be a little difficult for you to answer, but the person is asking, what does recovery look like in terms of arm usage?
Yeah, so the return is slow, and all patients go through a period worrying that they're not going to have any functional return, because it is a millimeter a day. Those videos that I showed you, it wasn't by chance that the earliest ones were at 9 months, because that's the earliest you're going to start to see some sort of functional return. And so 9 months out to 12, perhaps as long as 18 months, depending on how long someone's arm is, before you start to see return of function, with the idea that 24 to 36 months, you've got a full return of function, or you're going to be at the functional level that you can expect with the transfer. In regards to surgery, I put somebody in a sling usually for a day, 2 days, and then they can go back to their normal activity after a couple of days.
Okay. Would this allow for wrist side-to-side movement?
So it would not reinnervate the flexor carpi ulnaris, FCU function. If it was a distal reanimation, or depending on the level, that's certainly something that is targetable.
Okay. What is the time commitment away from home, I guess, sort of in terms of hospitalization and any follow-up on-site care?
So I let everybody go home same day, as I'm sure most people on this call can appreciate. The less I disrupt your routine, the better off you are. And so I let everybody go home the same day. As I mentioned, that sling is more just to prevent you from hurting the site or the surgery site. So there's minimal downtime with that. Okay. In terms of commitment coming to the hospital, it's usually for our post-op visits, 6 months, a year, 2 years, and then we added this 3rd year. So relatively low. What I don't know is how the ongoing COVID is going to impact that sort of visit. My suspicion is with the trend is it may make it easier, and some of this assessment may be done virtually.
Okay. Those individuals that are power chair, those individuals that are manual wheelchair users, would they need to use a power chair for a period of time? No?
No. And in fact, one of the gentleman I showed you that we gave back elbow extension, started using a manual chair after after a surgery, after he had good functional recovery.
Okay. How do you get into the program, and does it cost anything?
It doesn't cost anything. This is billed through insurance now, the nerve transfer. Most of the patients that I see have either Medicare or Medicaid, some sort of or some sort of equivalent coverage. As I mentioned, the physical therapy is covered by the Department of Defense, so there's no cost outside of whatever your deductible might be for sort of surgical intervention.
Can candidates fly into the States from other countries to have this procedure done?
Yeah, we have one international patient that came from abroad to be treated in the study.
All right. Would you recommend FES for transplanted nerves?
So it's interesting. One of my collaborators at Stanford asked about the same thing, and it makes a lot of intuitive sense to me. And we, Franklin, you and I can't recall if you and I talked about this, but it makes a lot of intuitive sense to keep that muscle viable. And so I said, I don't have any evidence that suggests it's going to make a difference, but intuitively, scientifically, it makes a lot of sense to use it. But I don't have anything to hang my hat on to support it one way or the other.
Okay. You mentioned that the nerves grow at a rate of 1 millimeter a day.
Yes.
What is the maximum length that is typically achieved?
Yeah, and that is a good question. And I've thought a lot about that with why we're seeing some differences in regards to return of function for the finger flexors. You imagine the longer that nerve has to regenerate or the longer course, the more opportunity is to disperse those regenerating nerves or axons that carry the signal. I don't think there's a distance in terms of this like we might experience with nerve grafts, if that's what the question is alluding to, where we worry the longer the graft, the less viable it becomes. Because these are still vascularized, the nerve pedicle or the length is less of an issue.
Okay. I know you talked about this in one of the slides, but someone is asking, would you consider a patient with a C3, C4?
Yeah, so as I mentioned, I have three patients, two which had good functional recovery. We have to be creative. Usually the only nerve we have is the spinal accessory nerve to work with. I've tried to use the platysma motor branch. I have an N of 1 that was not functional, and we have one patient coming up that we're doing a spinal accessory to phrenic nerve transfer to try to get him off his vent.
What are the possible complications post-op?
So what I worry about outside of the normal things you might think about with surgery, infection or a blood clot or something of that nature, my biggest concern is downgrading function. I've had one case where all the studies looked good in regards to donors and his exam was consistent where we didn't perform the transfer. As it turned out, his bicep, it was a variable zone of injury, and the bicep was not functioning. And the brachialis was the only thing providing elbow flexion. And so we couldn't do the transfer because my biggest concern is downgrade of function. And so again, as I mentioned, we've evolved, and I think we've learned a lot over these years in terms of who's a good candidate, but also minimizing those risks of downgrading function. None of the patients that were treated in this study had a downgrade of function. That is not the case for some of the peripheral nerve surgeries that I've done for brachial plexus injuries, where occasionally we will have some downgrade of function.
Okay. How do you compare and contrast nerve transfer results versus tendon transfer?
Yeah, I think we don't know, and I think ultimately it's going to be some combination of tendon transfers and nerve transfers. The functional return on a nerve transfer tends to be better than the tendon transfers. My orthopedic colleagues, that's in part, why the orthopedic surgeons are a big part of this. What we don't want to do is burn any bridges for future tendon transfers. And in part, you might say, well, why were your transfers so limited? Why? It looks like you had a lot more nerves to work with, or you could have been more creative. And that's true in some cases, but also we don't want to get into a situation where we've eliminated future tendon transfers down the road.
Okay. Does participation in this clinical trial exclude me from other clinical trials working on sort of hand and arm recovery?
No.
Okay. How do we apply?
So I think Linda, who really loads the freight and takes care of me in regards to all of our spinal cord injury studies, is the coordinator and the lead coordinator across all 7 sites. There are individual coordinators with each site, but Linda Quester would be the point person.
Okay. And by the way, everyone, we have been recording this session and we will make it available to everyone on demand next week. So all of the slides that you've been viewing will be available, and all the information will be available to all of you. This next question, somebody's obviously trying to push you a little bit farther.
Okay.
Can you take on a 39-month post-injury?
Yeah, I think we've made exceptions, and again, that 36 is not hard and fast, and I suspect all the sites would agree with me on that.
Okay, and then the same person is asking. Normally, a lot of function returns within the first 6 to 12 months post-injury.
Yeah.
So how do you sort of balance that versus, the fact that you are open to taking people 3 months out?
So the 3 months, that might be a little bit deceiving. It's 3 months of non-operative therapy, but 6 months is the soonest we would intervene.
Okay.
As you saw, the median for all of our patients was 18 months. Those patients that did have intervention, 9, 12 months, did have a trend toward better outcomes. There was one patient that was treated, I think, as early as 4 months, but he had a gunshot wound traversing the spinal cord with a complete transection that we treated very early. But I'm very, very cautious of that. I would say the group in Brazil is a bit more, I don't want to say cavalier because it takes on the wrong connotation, but I would say more aggressive in doing these pretty routinely at 6 months.
Is this procedure available on a non-clinical trial basis elsewhere?
So yes, those patients that don't fit into the DoD clinical trial, or perhaps there's some uncertainty whether they would be a good candidate, can still be evaluated at each one of these centers. All of these individual centers, I know each and every one of these surgeons personally, and also know that they do good work and they have a background in both spinal cord injury, spine surgery, as well as peripheral nerve surgery.
So those will be basically, like you said, covered under regular insurance.
Right.
Okay. Alrighty. I think those were the last questions. Yes, indeed. Oh, I'm sorry. What do you see phase 3 looking like?
Well, I think you hit upon it already. Is FES, does that have a role? Timing is most certainly still going to be a part of this, and then I wonder if at that point whether we'll ask the question of whether we should be doing tendon transfers concurrently or if we do them in a delayed but combined fashion.
How would that look like? A tendon transfer together with a nerve transfer?
Yeah, so my approach to this is we can always do tendon transfers. There's no time dependence to it. And so it's been a delayed evaluation. As I mentioned, my orthopedic colleague has a similar view. I don't know that I would combine them together, but you imagine some sort of arm where we would add that as an additional option down the road.
Okay. Sorry, one last question snuck in. What happens if insurance denies the referral?
Mm-hmm. Yeah, I don't have a great. I don't have a perfect answer for that. Again, most of these universities, if you have some sort of insurance, they should be able to have access here. And you see that most of these are state universities, and that was on purpose, and they're all academic institutions. And so even if somebody is underinsured, I don't want that to be a barrier.
Okay. So you mentioned the DoD grant pays for the therapy, right?
Right.
So with the hand therapists at anywhere USA, would they be billing? Who would they be billing, and who would be getting? How would they get paid?
And Linda may be able to comment on this. I don't know the structure of how those invoices come in But effectively, for simplicity's sake, let's just say they invoice us and they come out of the Department of Defense funds.
Okay.
And that's how most of the hand therapists from outside the institution are typically reimbursed.
Very good. Okay, I think that sums it up. Thank you so much, Dr. Ray. Really appreciate just so that I can add some perspective. We published the story about these clinical trials roughly about 4 weeks ago, and it was easily one of the most read stories that we've published all year long. So there's a lot of excitement and enthusiasm and interest in this trial. We know that the parameters are not going to sort of meet everyone's sort of needs, but just know that your work is very valued, and a lot of people from all over the world are following it. We were getting people, through social media asking about this procedure, whether it's available in their home countries, and of course disappointed that it was not. But just know that there's a great deal of interest in this remarkable study that you folks have taken on. I want to thank you for taking time out of your Friday evening to join us. And once again, everyone, the on-demand version of this thing will be available next week. And those of you that registered for this presentation, I have your emails, and we'll send you a dedicated email next week with a link to the recorded version. So everyone, have a great weekend. Thank you again, Dr. Ray. Good seeing you. And take care of yourselves.
Appreciate it. Have a good evening. Thanks so much.
Thank you, everyone.